Welcome to the second part of our webinar on corneal dystrophies. Today we will focus on endothelial corneal dystrophies, which are my favorite group of disorders. Before we start with rare diseases, and for the sake of context, I need to have a few words about Fuchs endothelial corneal dystrophy. It's a common disease that affects nearly 5% of population over 50 years. Clinical hallmarks are subendothelial deposits called guttae, accelerated rate of endothelial cell loss, and corneal edema in advanced stages. Fuchs endothelial corneal dystrophy is currently the leading cause of corneal grafting in developed countries. For example, in the UK, about 30% of all corneal transplants are because of FECD. The typical age when patients get grafted is over 60. Here you can see the typical beaten metal appearance as a result of corneal guttata. Advanced stages of Fuchs endothelial corneal dystrophy with corneal edema and scarring that affect corneal transparency. Subepithelial scarring. The familial nature of Fuchs endothelial corneal dystrophy was first reported in the literature in the 70s. The disease was noted to cluster in families and appeared to be inherited in an autosomal dominant fashion. The underlying genetic causes began to be identified after 2000 using classic gene mapping approaches and family cohorts of patients. These efforts led to the identification of only very few genetic causes, and for the vast majority of Fuchs corneal dystrophy patients, the molecular genetic cause was elusive. A real breakthrough, however, happened in 2010 when the first genome-wide association study was performed, and the association between Fuchs and common single nucleotide polymorphism situated within TCF4, which is a transcription factor, was identified. All this suggested that the genetics of this condition may be complex for the majority of cases. The same group went on to demonstrate that the signal of association was in fact due to common polymorphism in linkage disequilibrium with a non-coding intronic CTG repeat. And it was discovered that 79% of the Fuchs cohort harbored at least one expanded copy of this repeat, which means more than 50 copies, whereas only 3% of controls had expanded copies. So together with Moorfields Eye Hospital, we have also recruited currently nearly 1,000 cases with Fuchs endothelial corneal dystrophy and 550 controls. And here you can see the distribution of the CTG repeat length found. So generally 80% of patients have one or two expanded copies compared to only 4% of controls. 4 non-mutually exclusive mechanisms have been proposed to drive and or exacerbate the onset of CTG-mediated FECD. So remarkably, FECD is the most common human disease that it has been attributed to the expansion of repetitive parts of the genome. And it represents an attractive paradigm for modeling disease mechanism and testing therapies. So now we will return to rare disorders. One of them is correlated to associated endothelial dystrophy. It was originally described as a distinct early onset subtype of Fuchs corneal dystrophy. However, from the literature, it's clear that it's a different disease compared to common Fuchs or age-related Fuchs corneal dystrophy. It has buried guttae and markedly thickened descendant membrane. It's very rare. Globally, only 6 families have been identified, and 3 of these had a common founder. Another rare disease is posterior polymorphous corneal dystrophy. It's our favorite disease because we believe it has the highest prevalence in the Czech Republic worldwide, which is due to 2 different found mutations. Currently, there are 3 subtypes recognized, but they all have a common mechanism, and they're caused by dysregulation of the epithelium-mesenchymal transition. In the literature, you may encounter also disease or PPCD type 2. However, this is in fact called A2 associated dystrophy, which was shown in the previous slide. So there is insufficient evidence to continue using PPCD type 2. Typical for PPCD, and I will show you many clinical images later are geographic opacities, vesicle-like lesions, bends, and irregularity of posterior corneal surface. Some patients may have also band keratopathy, peripheral iridocorneal adhesions, iris atrophy, correctopia. PPCD1 is caused by promoter mutations located in OVO2 or located in the promoter of OVO2. So generally, one would say it's rare globally, except for the Czech Republic. There were only 6 families described today. However, because of the already mentioned founder effect, we have additional 21 families currently with more than 120 living affected individuals. As you probably know, corneal endothelium is composed of only one layer of regular flat cells. They do not divide. However, in BPCD, the endothelium is or can be multilayered, displaying abnormal morphology. So generally what happens with this dysregulation of EMT MET mechanism, the cells start to divide and then they start behave strangely. Now I will show you some typical findings that we've observed in PPCD1. There is a patient that was already grafted in the first image and finding in the other eye, then his daughter and his grandson. So you may note this irregular opacities at the posterior corneal layers. And again, especially in PPCD, we value examination in retroillumination. It's very helpful. Another patient, which is only in his 2nd decade of life, but he also has corneal edema and he has band keratopathy nasally. PPCD, if you graft it, which is the common procedure how to manage the disease, can be recurrent as the abnormal endothelial cells may slowly grow from periphery onto the transplant and generally somehow overgrow the grafted cells, as you can see in this image. Another patient, in him note iris changes and atrophy and synechia, and also marked corneal edema. So that was PPCD type 1, and now we can move on to PPCD type 3. Again, rare disease globally. There were reported less than 70 families, and because we meticulously searched for these patients in the Czech population, so 1/3 of these families were actually from the Czech Republic. They have, unlike PPCD1, they have mostly unique mutations, so each family has a novel mutation, and approximately 1/3 of them arise de novo, which means that parents are unaffected and suddenly they have a child with PPCD type 3. It's likely underdiagnosed because if it was not underdiagnosed, I can't explain why we would have 1/3 of our families globally. So there is certainly a lot of options for ear and eye centers to depict these patients. There's also marked phenotypical variability, and it starts from patients with congenital edema, although there are very few, but this can happen as congenital edema, to only reduced endothelial cell count. So you can't find anything in these patients, but they have a reduced endothelial cell count, and some of them have even some of them even carry the change, but do not have any corneal changes, so they're non-penetrant. In this image, you can see typical vesicle appearance, or to me, it resembles blebs, and it's the typical sign which is often mentioned in the literature. Another patient where you can observe knife opacification of the posterior corneal layers, and a patient who didn't want to get grafted, so he had marked corneal edema, opacification, and band keratopathy. Finally, when he was around 60, we persuaded him that if he wants to see something, he has to have a corneal graft. And now he's very happy, bilaterally grafted. Last patient with PPCD3 that I'm going to show you was actually misdiagnosed as anterior segment dysgenesis, and only after genetic testing and identification of ZEB1 loss of function mutation, we actually realized that she has PPCD3. Here we can see her corneal endothelial changes using specular microscope. So I've been trying, and I've been always wondering if there are clinical differences between PPCD1 and PPCD3. In other words, can I guess what's PPCD1 and what's PPCD3? So the answer is not that is inconclusive. You still need molecular genetic testing, but when we compare our groups of PPCD1 and PPCD3 patients, we can make some differences globally across these groups. So PPCD1 is progressive. We hardly see the typical vesicular lesions, unlike PPCD3. We haven't observed a patient with congenital edema, but that only mentions the Czech variant, whereas the British variant, which was previously referred in the literature as autosomal dominant congenital hereditary endothelial dystrophy. In these individuals, they all have severely visually impaired and many have congenital edema, but in the Czech variant, which is different, we don't observe it. PPCD1 has 100% penetrance, so all individuals that carry the disease-causing mutation have the disease. We also observed approximately in 30% of these patients secondary glaucoma, which can be very difficult to manage. 42% necessitate grafting. When we perform pentacam or any keratometry, there is no corneal steepening. Unlike PPCD3, with over 2/3 of patients actually have corneal steepening. So if you see PPCD with corneal steepening, it's very likely PPCD3. What's good about PPCD3 is that the rate of secondary glaucoma and the necessity for grafting is lower. So again, if you have the diagnosis at molecular level, you can provide better counseling to the patients. In PPCD3, I already mentioned that there are cases that carry the disease-causing mutation but do not show any signs of the disease until adult, and they do not show any signs of the disease until they're old. So we had one case 70-year-old, and she did not have any corneal changes. When we perform specular microscopy, we think that in PPCD3, or not we think, we've observed in PPCD3 decreased corneal endothelial cell density usually. So there is apoptosis, but in PPCD1, we occasionally observe really increased endothelial cell density, telling us that the proliferation is probably higher than in ZEP1 if in ZEP1 it occurs at all. So that was the PPCD1 and PPCD3, and now we can move to PPCD4. It was the clinical entity was delineated recently in 2018 when we identified that it's caused by, again, regulatory mutations. This time in Granny had like 2 gene, but then all genes involved in PPCD, oval 2, Z1 and Granny had like 2, as you could see in some of the previous images, are actually mutually regulating their transcription, so it all fits. And globally, again, this type is very rare. Globally, there were 7 families described of these 4 Czech, and now we also have 1, and one of them was de novo. Currently, I'm aware about only 28 patients of these 5 are of Czech origin. In this dystrophy, we don't have such a huge cohort of patients, so it's difficult to compare the clinical changes, but we've noticed that about 1/3 of our cases required grafting and about 1/3 develops secondary glaucoma. Some clinical images from our patient. Again, you may notice opacification of the posterior corneal layers and an irregularity of the posterior corneal surface. There may be also band keratopathy, iris changes, correctopia, and decreased endothelial cell count. Another condition that needs to be mentioned, and I believe the fact that PPCD is usually described in the literature as non-progressive condition is actually because we're not looking, or it's actually because we were not looking, or the authors were not looking at true PPCD, but at posterior corneal vesicles. These are mainly sporadic, congenital, static, can be unilateral, asymptomatic, usually not decreased in best corrected visual acuity. There may be also bands, not only vesicles. And we've actually made this observation in 38 individuals, which we all screened for known causes of PPCD, and we did not identify any mutations. So it's a question whether this is a disease that it's genetic at all or not, or whether the genetic causes of posterior corneal vesicles are different. So I guess we will continue screening them, and hopefully we will be able to give some answers. So next clinical entity is congenital hereditary endothelial dystrophy. It's a disease which I would say, although rare, it's relatively common. Again, I've counted in the literature more than 70 families described globally. And of these, 7 were checked. We've identified 7 Czech families. It's caused by mutations in SLC4A11, which is a multifunctional transporter with an impact in cell morphology and differentiation. And one of its functions also that it's a water permeable channel at the basolateral cell membrane of endothelial cells. So facilitating fluid reabsorption in the aqueous humor. The disease is characterized by diffuse corneal edema since birth, but there may be also hearing impairment. But the hearing impairment has a variable age of onset, and together with hearing impairment is also denoted as a Harborian syndrome. Because there is congenital edema, patients develop amblyopia, often strabism, they have nystagm. Some examples that we observed in our patient: typical milky appearance of cornea observed since birth or shortly after. And what's really characteristic for this disease is marked corneal thickening. So you can see the corneas have double normal thickness. In this image, you can also see in C a patient that is over 70, and so it's rarely you see patients that were not grafted with these findings. She also has what you may note secondary degenerative lipid deposition. The last condition is X-linked corneal endothelial dystrophy. Although the gene has not been identified yet, and there is only one family, the family had 35 affected members, so it's pretty convincing that the disease exists. Males have congenital edema and irregularity of corneal endothelium, and again, what you can expect: nystagm, band, keratopathy. Occasionally, females may be asymptomatic, and they may have posterior corneal surface which resembles moon. And there is again multilayering of corneal endothelium. So let's talk about differential diagnosis. Imagine you have a sporadic male patient with no family history, manifesting with bilateral congenital edema. So below are all possibilities which can happen. So which one will you choose? So I think, again, you need genetic testing to get near the diagnosis. So the options are, and the most likely option would be congenital hereditary endothelial dystrophy, recessively inherited. But then there are several cases of PPCD3, which was de novo, so again, sporadic. The parents had nothing. Occasionally, it could be congenital glaucoma. However, here you would expect probably larger globe, but still it's been described in the literature. Another choice is congenital cytomegalovirus infection. And although to date there is only one family, but the option still lies that you're looking at X-linked corneal endothelial dystrophy. And we believe, based on our collection, that there are also other novel molecular genetic causes that have not been picked up for inherited endothelial corneal dystrophies yet. But if you identify typical PPCD3 or CHET-associated mutations, you have the diagnosis. In patients with late onset corneal edema, differential diagnosis may not be also easy and may be also difficult. So imagine you have a elder patient with bilateral corneal edema. So it can be corneal dystrophy, PPCD, or late onset Fuchs, because the edema is so severe that you can't really have a proper look at the corneal endothelium, make your judgment. But it can be also a consequence of surgery, injury, infection, eye syndrome, although eye syndrome is not bilateral, but there are many options. Even distinguishing mild PPCD from Fuchs may be difficult, as you can see in these images. So subtle PPCD with corneal edema versus Fuchs endothelial corneal dystrophy may not be as easy as it seems, because you're not always facing the typical signs that patients have. So if they have nice full posterior corneal vesicles, then it's easier. But not all patients have that. And last case, what can happen is the dual diagnosis. So I always wonder, what are your chances to win a lottery compared to having two different rare corneal dystrophies? But we did observe a patient with Snyder corneal dystrophy and posterior polymorphous corneal dystrophy type 3, and both were characterized at molecular level. So we identified the disease-causing mutations. So in conclusion, talking about corneal dystrophies from A to Z, corneal dystrophies are almost exclusively rare disorders. Knowledge about their existence is important for differential diagnosis and personal treatment. Molecular genetic analysis may be essential to establish the correct diagnosis. Studies on disease mechanisms, which are allowed by identification of the molecular genetic cause, bring novel insights and hopes for targeted therapies. This is particularly true for TCF4 mediated Fuchs endothelial corneal dystrophy. Again, I have a question. What kind of rare corneal endothelial dystrophy have you seen? Thank you for your attention.